Well, thank you very much to all the speakers for staying on time. If I can ask you to come up to the podium now for the discussion. As you see, we left significant amount of time for discussion today because I think that's the most important part. So don't be shy. Come up to the microphone, and if you are shy, send us, please, your question that's going to appear here on my computer, and I can read that question loud to the audience. While some of you get encouraged to ask a question, let me start by asking, we need one more chair. John, can you do us? Yeah, thank you. Two more chairs? No, one more. Great. So let me start by asking Jaime, um, you mentioned very nice in your presentation about the crural defects, less than 5% repair and now over 10% repair. Is there any limit where you go in there, see a hernia, and you say, as an expert in bands, I'm not going to put the band in? Or is it in 2013 so that you just fix the hernia and keep going? Because we have, I think, that perception that if the patient has had a hernia, band is contraindicated.
I think the limit will be if you fix the hernia and your anatomy is completely distorted that you cannot put a band appropriately. But if you can fix it and the anatomy looks doable, then you can just go ahead and put a band.
So I'm not sure that the microphone is working properly. My question really is, we are concerned about slippage, and when we repair a hiatal hernia, we are adamant and we are careful in dissecting very nice with a big space behind the G junction. Is that a concern that because of that you might have a posterior slippage or not?
And it is not. You know, I had the same concern as you had in the past. We have done a lot of posterior repairs, crural repairs posteriorly, and as long as you stay above the lesser sac, you go to the pars flaccida, you mobilize the esophagus down, and you find the crural defect, I haven't seen a posterior slippage from that.
Thank you very much. So Dan, Dr. Heron, you mentioned to us about internal hernias, and we're not going to get about we should close them or not because people are getting tired about having that discussion.
Everybody but you close.
Exactly. So we have to close all the defects. Let's start by saying that to make you happy. But I think the problem is not identifying them properly and let these patients go home, as you mentioned before. Any tricks, any tips? Is a CT scan the way to go, or is it the symptoms? Is the patient coming with periumbilical, crampy, abdominal pain going to the back, a patient that we have to take to the operating room, or should that correlate with a CT scan, et cetera, et cetera?
Well, I think, you know, there are internal hernias and there are internal hernias. If you see a patient like that one I showed with the dead bowel, obviously that's a severe example. But more commonly, they show up with this epigastric pain which comes and goes, and they've been often worked up with upper endoscopy, and sometimes there'll be some incidental finding, and maybe that little tiny ulcer was the cause of the pain, or maybe they'll have had a CT scan with some other incidental finding, but none of these imaging studies or endoscopies are going to show the actual hernia defect. The only way you're going to see that is with a diagnostic laparoscopy. So I would consider the perfect diagnostic study to identify an internal hernia is a diagnostic laparoscopy, and you can repair the defect in the process.
So in other words, you're advocating a more liberal indication for diagnostic laparoscopy instead of seeing this patient doing CAT scans and colonoscopies and, I don't know, sending the patient to the psychologist, just take him to the OR and do a laparoscopy, correct?
Well, I mean, obviously, if a patient has postprandial right upper quadrant pain after gastric bypass, I mean, you have to remember the other sources of abdominal pain. But if a patient has epigastric abdominal pain after gastric bypass that has not been diagnosed definitively through other approaches, that's a solid indication for a diagnostic laparoscopy.
John, you talk, yeah, go ahead.
Just to follow up on Dan's comments, I mean, that's the classic history, the periumbilical pain, the coming in, the coming out of the pain, and it has to do with the hernia going in and out of the defect a lot, and sometimes you can miss it on a CT. I think the big thing is if you do, it's going to be classic if you see it on a CT, the swirl sign, and the big thing to remember is to start from the cecum and reducing it. You can really get in trouble if you do it the other way around.
Now, John, we talk about reoperative surgery and pain. You have the patient of Dan now that comes with that kind of periumbilical pain. It's vague. The CAT scan looks normal. You take him to the OR. and you see that big candy cane there, and that the pouch is a little bit enlarged. Do you think we should resect that candy cane and enlarge pouch?
I think it's a reasonable idea. I mean, the big concern with that redundant end of the root limb is potential for bacterial overgrowth, and it's something that can affect motility and pain. It's kind of the reverse of the J pouch at the very top. It's easy to test. You can do hydrogen and methane breath testing, and it's treatable. But the other part of it too is that it may not be just the overgrowth. It may be the fact that food settles in there and kind of refluxes back up. So I probably would trim it if I don't have a reason for any other reason for pain.
There is a question, please.
Yeah, Mohammed Daman from Ohio.
Could you speak up louder, please?
Yes, Mohammed Daman from Westchester, Ohio. I want to thank the panel for sharing those valuable points with us. I have a couple of questions. First one with regards the sleeve and the reflux. Most of this data, is it mainly just the data that's pulled for the reflux? Is it just mainly subjective from the patients, or there was like some pH studies done?
James, did you understand the question?
There's an echo. I couldn't really.
Yeah, we have an echo here. Is it that the data of the reflux, you mean that it's subjective? Did I understand properly?
Yes, subjective, or there was like more like, pH studies done?
Yeah, if your reflux data was based on...
The reason I'm saying some of the patients may, because, the sleeve being, more restrictive, and, if they overdo it with the eating and they, force that rather than just actual symptoms of reflux.
Yeah, no, it's a good point, and if the experience in the literature is quite variable. Many of the reports are just based on symptoms. Some are taken to the next level with gastroscopy, and then there are some reports that are out with pH testing, and it's that variability that makes it difficult to interpret those. There's a systematic review where you have reports saying there's an increase in reflux, other studies saying there's a decrease in reflux, and pulling it all together is difficult for that reason. But there's no question objectively that if you use gastroscopy, you'll see people post-sleeve gastrectomy who didn't have erosive esophagitis before and who now have erosive esophagitis. So it's absolutely a real phenomena that occurs. But it's that variability in testing that contributes to the heterogeneity you see in the literature.
I think what you need to look at, there's a recent publication, I think it's this month or last month, from the Cornell group on people with reflux generally, and the number of people treated without, not weight loss surgery, just people with GERD. And the correlationship between pH and impedance-metry and actual reflux and the symptoms of reflux is not very good at all. So there's a lot of people taking PPIs that have no documented reflux when you do pH-metry. So I think, I think you can make an argument for weight loss surgery and not doing upper endoscopy before, but if you're going to do the sleeve, I think you need to do upper endoscopy before. There's a lot of patients that have fairly significant erosive esophagitis and are completely asymptomatic, and when you do a sleeve on those patients, you can get into trouble. You've got to know whether those patients have Barrett's or not, because I think Barrett's is a formal contraindication to a sleeve gastrectomy, and I think you need to know what you're getting into before. So I think you need to really work these patients up a little bit before you do, and the first step is endoscopy.
Let me ask Dr. Ponce, Jaime, but isn't it that when we lose weight, the mechanisms of anti-reflux to some degree get corrected? We see that obese patients lose weight, the reflux goes away, at least their symptoms, and the Miser scores improve. And we've seen it from the banding data, patients that they claim that after banding the reflux gets better. I don't think it's a mechanical effect, I think it's the weight loss. So are we advocating now that every patient should have an EGD, every patient should have a pH manometry? What do you think?
Well, depends on what you're going to do. I mean, I agree with Alfonso. I mean, if you're going to do something like the sleeve and you're going to compromise the ability to fix reconstruct the esophagus from a potential cancer, then in those cases, you probably need to do an endoscopy. I mean, a band, you probably need to do it only on the ones that are symptomatic, on the ones that you're concerned about it. I mean, band is pretty benign. I mean, you can still do it afterwards, and you can still take the band out.
So Dan, this is a 7-year-old male, has Barrett's esophagus, mild dysplasia. This guy needs his back fixed, had a heart attack, is on Coumadin, doesn't want the band. Would you do a sleeve on that guy because of Barrett's? Are you going to say no because of Barrett's?
Well, as Dr. Morton said, just because you can do an operation doesn't mean that you should. No, I'm not going to do a sleeve on. I'm not going to put a band on the guy. I'm not going to put a sleeve in this guy. I would consider a bypass if he has Barrett's, because that's going to be the most definitive treatment of his reflux. The question would be, is he a safe candidate? So I'd have him, fully evaluated medically and assess if he was a safe candidate. But I would do a bypass on him.
So Alphonse, now a month into the bypass, the patient develops a marginal ulcer, gets admitted to the ICU, the hemoglobin of 7 and chest pain. What do we do now?
Have a look.
Have a look. Okay, everything stops. You put him on PPI, goes home, PPI twice a day, and keeps coming back to the emergency room with bleeding.
From an ulcer.
From an ulcer. One of those marginal ulcers I'm going to hear today from Dr. Wiseman that never heal. Well, the point I'm trying to make here, Alphonse, and I want you to comment on this, I don't think that Barrett's esophagus per se should be a contraindication. I think in the elderly patient, without trying to put an age, if you need a second procedure like doing a transplant or doing a CABG or getting hips replaced, you can do a sleeve, get them to lose those 80 pounds in 5 months, and then do the procedure. I don't think that Barrett's per se, it's an absolute contraindication. Let me get Alphonse, and then James, you can comment.
So I don't think there's anything that's a never event in surgery, but I think, and I agree that perhaps Barrett's is probably not as bad as we used to think.
Right.
And I think there's a lot of endoluminal therapies that can modify Barrett's. But if you need to document in your chart that you've spoken to the patient and that the bottom line on this is that if he does get Barrett's and needs an operation on his if he does develop esophageal cancer, that you can't pull the stomach up anymore because you're attached to the lesser curve, it's not going to reach. So you're condemning this patient to a colonic interposition or a small bowel interposition, which is all doable. I'm not saying it's not. I don't think gastric bypass is really that bad an operation. I've done a couple of thousand of them, so I really know that operation fairly well. Yes, you have patients who have bad outcomes and resistant ulcers. Usually when you go back once and deal with it, it's because your pouch is too big. One patient group that really gets ulcers a lot that I didn't think before is patients with gout. I think those patients often take non-steroidals when they have a sort of semi-attack and they don't tell you about it. But generally speaking, the really bad ulcers, and I've had them, respond to one surgery. The ones that keep on coming back, I don't really know what to do with them either than put them back together. Mm-hmm. And you don't have to operate every patient who comes in. There's some patients who just, you can't operate on them. So.
James, you wanted to make a comment?
Yeah, I was just going to say that, there's a huge amount of variability when it comes to gastroesophageal reflux. There's a huge amount of variability when it comes to Barrett's esophagus. And I think it's hard to paint the whole thing with one brush. The spectrum on Barrett's esophagus is somebody who's, picked up, short segment, not on a PPI. This is a total different disease entity than somebody with a large hiatal hernia with, multifocal high-grade dysplasia with a Barrett's esophagus. And so your algorithm for both of those are going to be different. And so just say, they got somebody did a biopsy and somebody saw intestinal metaplasia, we need to do a bypass, change my whole algorithm because of that one finding. I think it's a little over the top. And so I think you need to individualize. I think we have, again, one of the questions came up, does everyone who needs a sleeve gastrectomy need to have a gastroscopy or a formal evaluation of their upper GI tract? That hasn't been my practice. And like I said earlier, a big part of my practice is endoscopy. The reality is there's many series out there, several hundred patients, and you're looking at people who get severe gastroesophageal reflux is in the order people who need reoperations in 1 in 100, 1 in 200 sort of numbers. And so this is the people that essentially you're trying to identify with your preoperative endoscopy. So the question is, do you need to do 200 pre-op evaluations to identify those 1 or 2 patients? It seems like a large number needed to treat. I mean, if it's not unreasonable to do it, but I don't think you necessarily have to as far as good care to screen it.
You have another question, sir?
Yeah, just to follow on your question with regards, not just simple, like a little bit separation, a little bit hiatal hernia. What if you had a good size paraesophageal in the patient that you were planning to do a sleeve or ruin why? I mean, we all agree definitely weight loss is the best thing that's going to protect your repair. But is it safe to do the repair at the same time with the risk having a leak in the chest versus in the abdomen?
Did you understand the question?
A paraesophageal hernia, is that what, yeah, the timing, staging of it?
Yes, yeah, you're going to do, a sleeve or a bypass, and then you have a nice paraesophageal, and I guess, do you do the repair? I mean, we agree that, weight loss, definitely is what are going to protect that, hiatal repair. But would you do just the repair and then come back and do the sleeve or the bypass, or do both at the same time?
Okay, paraesophageal hernia. Sleeve, bypass, stage approach, or John?
I'm a believer, if it's a true paraesophageal hernia, not, a little dimple, I'm in favor of doing it staged personally, because some of those hernias can be quite large, and you take down a lot of the blood vessels, and you're not really sure about the degree of blood flow to those areas. So if it's a real paraesophageal hernia, then I will do them in stages. I'll fix the defect first, then I'll come back and decide what to do. In general, I don't do a band in those patients. I'll do either a bypass or a sleeve.
Jaime, you're saying yes?
Yeah, first, a true paraesophageal hernia, you wanted to make sure that you fix it and look at your anatomy. It is going to be a little bit more challenging to put a band on those patients sometimes.
Alphonse?
I've pretty well gone through that whole algorithm and sort of gone back and forth and tried to do different kinds. I've come to the point that if you have a paraesophageal hernia, doing a sleeve on these patients, and we did this way back, and we presented it actually at this meeting and got poo-pawed by all the foregut guys, and now they're talking about doing sleeves with paraesophageal. The problem with a sleeve and a hernia, a hiatal hernia, is it's probably a bigger problem than we think. Because if you make it too tight, you really get a lot of dysphagia. If you make it too loose, you end up almost with the same diagram that Jaime had for this. You end up with a part of the sleeve that pops through the hiatal hernia and then gets this constriction at the hiatus. And you end up with a part that's almost like a fundal pouch that's over it. And it's really hard. And the worst thing that you can get with a sleeve is that the whole sleeve goes up and you get this sort of horseshoe-shaped part of the stomach that's actually in your hiatus on a recurrence. So I think what I've really come down to is I think you can fix the paraesophageal and you can actually probably do a nice gastric bypass with the sleeve. I'm going back. I was a proponent for about 5 or 6 years. We were doing them with sleeves, and then you start to see the longer-term complications of the sleeve if they come back and see you, which is not a given, especially in the environment where I work. But I think the bypass might be the better operation for the paraesophageal.
So, John, I do the sleeve, the patient comes back to see you and has weight regain. After what you heard from Alphonse, would you recommend this patient to have a BPDDS, or would you do a bypass? Because Alphonse is telling us a bypass is a great operation.
Well, he was whispering other things to me about the DS here, but I would not do a DS personally. I would go ahead and do a bypass. It's, I have a larger experience with a bypass than I do with a DS, and if you look at some of the long-term data, the differential between weight loss, long-term between the two operations is not huge. The other thing is we got to consider it's more than weight, it's comorbidity resolution and all those other things, and I don't think it's that much of a superior operation. So personally, I would go with a bypass.
Dan, you mentioned in your presentation about the circular stapler being one of the, I would say, errors in judgment in your experience. How can we prevent strictures when we do sleeves and bypasses besides the size of the stapler? Any other tip that you're giving us to prevent that complication from happening? Because John showed us very nicely that this is one of the major mistakes that are happening, strictures. You want to do a small anastomosis of the bypass anyways. It's the only operation we try to do a small anastomosis.
I mean, certainly for years we've talked about intentionally making a very small anastomosis, but again, if you look at these patients 2, 3, 4, 5 years after their bypass, regardless of whether you've used a 21 stapler, a 25 stapler, a linear stapler, hand-sewn anastomosis, permanent sutures, absorbable sutures, these anastomoses all dilate. And it's essentially a normal finding to see a gastrojejunectomy which has dilated to the width of your pouch if you have a long, narrow pouch as part of your operation. And this is not an anomaly. This is what happens with the evolution of a gastrojejunectomy. So I think if your question is how do you avoid stricture, there's good evidence out there to say that if you use a circular stapler, you should use the largest one you can, a 25 versus a 21. You can reduce it still further by going to a linear stapler or a hand-sewn anastomosis, but you're never going to get it below a 2 to 3% rate. Even if you do a perfect anastomosis with absorbable hand-sewn technique, you're still going to end up with a low but non-zero stricture rate.
So Jaime, what do we do with this patient that had 15 years ago a wonderful gastric bypass and has a stricture, marginal ulcer, and keeps coming, but the insurance says, oh no, can have only one bariatric procedure? How are we addressing that problem as a society, and you as the current president? You have so many things to address lately, but that would be your next presidency one day. So
no, that's a real problem. You know, some insurance companies are stating that there will only cover one procedure, so you're just going to have to do a peer-to-peer medical reviewer with a medical director discussion about how this patient is having a significant problem that is going to need to be fixed. I mean, the fact is you're going to need to take it to the hospital one way or another. You're going to need to fix it. I mean, it is a problem. But it is a problem. There is an initiative from the SMBS, and we're going to try to develop a task force to start addressing some kind of guidelines or document that describes revisional operations and the fact that this is a chronic disease that is going to require, in some instances, revisional surgery. This is a complex issue because revisional surgery, as you saw from the first slide from John Morton, it has 20 million versions, and we're just going to have to come up with a more generic statement, specifically for the insurance companies that are trying to give us a hard time.
Yes, John.
I think it's critical. You know, as we're doing more and more of these operations, there's going to be more and more revisions out there, and the discriminatory practices of the insurance companies are going to have to be held to some sort of standard. We don't have one stint, you know, when you get heart disease, and certainly we need to have more opportunities to deal with the chronic disease. And I think the task force that Jaime's put together is going to really hopefully make a difference there, where we can get these insurance companies to do the right thing.
Well, I think that no patient should go to an operating room with, I would say, approval of having one operation only. It doesn't exist in surgery that you can have only one operation. You should always be covered not only for the procedure but also for potential complications. And obviously they understand, but they don't want to understand that there is a difference between failure of weight loss, weight regain, and a complication. One thing is a gastrocgastric fistula, an ulcer, a bleed, or a hernia. This is not bariatric or weight loss surgery anymore. It's something different. We ran out of time, but I think this panel was excellent. Thank you so much for coming and staying, and we're going to move on now. Thank you.